And Professor Norbert Ndjeka, who is head of National TB Program at the National Department of Health, joins us now to further this conversation. Thank you for speaking to us. Just looking back to some of the comments that you made, the discussion around poverty, some have called TB the poor man's disease, but I want to talk about changing those perceptions. And the incident rates in South Africa were said to be the third highest in terms of the number of incident cases of TB globally. But you seem to talk about hope that we are now curing this, and it's not necessarily the country's main cause of death anymore.
Yeah, thank you so much for the invitation. It's really exciting to see that we're able to treat most of our MDR TB patients for 6 months, cure even more than we could cure in the past. It's really exciting. But I must say that our TB epidemic is essentially driven by HIV. Yes, we do have other situations that lead to TB. I mean, if people live in congregate settings, they live in hostels where they are confined to small space, many people. It's really, what drives the transmission. But HIV is a key driver, and like I said, half our people with TB are people living with HIV. So we got to manage both conditions, TB and HIV, in order to get full benefits for both conditions. Yeah.
You talk about HIV. There was a time that I was involved in projects around TB awareness. They were talking about the triple threat, not just HIV, TB, but talking about diabetes as well. So just talk to us about the relationship between that and how it is fueled by a concomitant hyper-epidemic TB.
Yeah, diabetes is also a risk factor for tuberculosis because someone who's diabetic has the immune system weakened, and that is likely to lead with to tuberculosis in similar way as your HIV lowers your immune system, then you become more susceptible to tuberculosis or active tuberculosis. I must say that if we're getting 10 million people per year with active tuberculosis globally, the number of people with latent tuberculosis is bigger than 1 billion, maybe close to 2 billion or more. So there are a lot of people who have latent TB, but the risk factor now to get this latent TB, which is asymptomatic, people live, they don't know about it, they're not bothered, but when you get HIV, your risk of developing active tuberculosis is very high. Same applies to diabetes. That is why we need to prevent those conditions, but also for control of diabetes is a problem, because if you have diabetes that is poorly controlled, your TB treatment will not be effective. So those are the things that we have to deal with when we support our patients who have TB and diabetes.
As you say, awareness is important and prevention is better than cure, as they say. So I want to talk about the technological advancement and also the availability when it comes to screenings and testings. So some people will only, for instance, start trying to do that when they feel an irritation in the chest or a cough that's not going away. But how do you ensure that people are proactive, and where do they go? Because the lack of information is often the problem.
Yeah, no, that's a very interesting question. Like you said initially, we're a high burden country, we're a hotspot. So what we've done over the last 2 years, we've changed our screening and testing policy. And we're saying that patients at higher risk groups. Patients who belong to these high risk groups need to be tested regardless of symptoms. A lot of people are still battling with this idea, but we have evidence that our patients, for example, people living with HIV, tend to be more at risk of developing TB. Therefore, we test them annually, regardless of symptoms. That's our policy. And many countries have not really started to do this, but we have a good reason to be doing this. If you close contact of somebody with tuberculosis, you live in the same household, and the one person has TB, you don't have, you should be tested. In the past, we used to observe such people, but also individuals who have recently finished treatment, we test them 6 months after finishing treatment and another 6 months just to make sure they do not relapse. So these are the 3 high-risk groups that we've identified in the country, and we test them regardless of symptoms. Of course, the other people, we look for symptoms. We ask them, are you coughing? Are you losing weight? Are you experiencing fever at night? So we ask all those questions. If you say yes to one of them, we need to be testing you. We got molecular technology. We call it TB NAT test, which we give to all TB presumptive individuals in the country. And we also use digital chest X-rays to see whether there are lesions on the lungs, because some people are not coughing, but when you take a chest X-ray, you look at their lungs, you see a lot of issues, a lot of damages, which can then lead to a good diagnosis. So those are the efforts that we are making to find TB early, unlike just sit and wait for people to complain. But also we do a test where we use urine for people with advanced HIV, because with that category, your normal test, sputum test, will tend to be negative even if they have tuberculosis. So we use a test that is using urine to try and diagnose tuberculosis in that group of patients.
Professor Ndjeka, you spoke about vulnerable communities, especially those who are in an enclosed place or space and has a larger population, like correctional service institutions. The mining sector, for instance, I know is one of those that are vulnerable. But I want to understand, in cases such as this, where you have institutions run by the state on public funding, what are the practices in place for the National Tuberculosis Program in terms of the management or monitoring thereof, but also the collation of data, both at a provincial and district level?
So what we expect, which we ask from our colleagues who run general hospitals, is that when the public walks into a hospital, there's a good opportunity to do screening for tuberculosis. And so asking questions would be very good, and various strategies are deployed in the facilities to try and identify those who live with HIV and test them on an annual basis. But of course, if they have symptoms, you don't have to wait for a whole year. So there are various strategies that are applied to make sure people are tested at those facilities. Not tested, actually screened. So as you screen, you also identify in the process those who don't need even screening, who have to just be tested regardless of symptoms. So these are the various things that we do, but we also advise our colleagues not to mix patients. It's advisable that if you have patients in the TB ward, for example, they should wear masks. And healthcare workers who treat TB patients should wear other masks, which we call respirators, to protect themselves. So those are the various policies that we have in place. But of course, it is work in progress. Ideally, because we are a hotspot, most people who go into area where they're likely to meet TB patients, like internal medicine wards and all that, should wear masks. So these are some of the things that we really have policies in place, but of course implementation will differ from one place to the other, and we really want to strengthen that into these facilities, state facilities, so that we prevent tuberculosis. We also have measures like open window policies, which have been there for a long time. When you open windows, those who cough, who have TB, will have their bacilla move out of the room. So it protects the people who are in the vicinity. So there are various things, of course, that we plan to do, but at this stage, those are some of the few measures that we have in place.
All right, Professor Ndjeka, I'm afraid we have run out of time. We're going to have to leave it there, but thank you so much for your time in giving us that update in terms of progress on the management and monitoring of tuberculosis.